So Zander, you're going to be like the supervisor here, and you'll be communicating our instructions if it's not clear. And it's Crystal, is that who we've got today?
Yes,
Yeah.
I'm Crystal. I'm Crystal in my first year of endoscopy.
Great. Okay. Well, we heard all the learning contracts earlier. So basically, we need to know why we're doing this procedure on this patient.
So this is a 58-year-old patient with just a positive IFOP, completely symptom-free. So he's actually just coming from his bowel cancer screening index colonoscopy.
Good. Okay. And are we using propofol or conscious sedation?
Yeah. No, we're using propofol. So it's a propofol-assisted endoscopy.
Okay.
Colonoscopy. Yeah. Yeah, yeah. So she's using air because she's not used to doing the water intubation.
Okay.
Perfect. So we hear and see everything.
Yes.
Okay. Yep. Roland, you had a chance to meet already?
Yeah, we very briefly met. Chris, we understand that this is a 58-year-old man, positive fit, no symptoms, index colonoscopy. And we're using a cap, and we're using air insufficient. And I like what I see so far. Nice tempo, not too fast. Getting good views so far. I did notice that Crystal had the umbilicus over her left wrist, which is fine for the moment. She did try it outside the wrist and then put it back into the usual position, I suspect, but that's fine.
Yeah, we had a talk about that earlier because in her center where she's trained right now, the processor is actually on the other side of the bed. So that was something to get for her. So
well, while she's doing so nicely, there's not much for us to intervene. I would, as a trainer, I would normally just allow the trainee to progress like this and wouldn't say very much. But for people who may be watching this in the future, I think having the processor on the opposite side of the bed just doesn't make sense. I mean, it just creates big problems, particularly with the umbilicus. And it's unnecessary. So, Crystal, you're sort of struggling a bit there. What's your problem, do you think?
At first, I didn't see the lumen very well. It was very floppy, I think, and now I have a difficult turn to make.
Yes.
So I'm struggling to make the turn.
And what I'm noticing from inside the room, I'm not sure if it's clear on the room view, is that she's twisting her wrist like this. I'm not sure if you can see it, but she's really twisting her left wrist like that.
Yes. She's having trouble applying anti-clockwise torque. Is that what you mean?
Yeah.
Yeah.
I'm having some resistance here already.
Yeah. So do you think it's possible just to stop there for a second? And so when we say stop, what we mean is stop progressing, but don't let the scope fall backwards. All right. So if you can try and maintain that view. So why do you think there might be a lot of resistance here?
I think I'm already making like, what is it? A hammer? No, alpha. I'm making a loop.
Yep, a loop is forming. And just describe what you see on the green screen.
Yes.
Okay, Should I help you?
It's the first time for me
Yeah.
working with the imager, so I don't know what to think of it.
Okay. Well, you see the scope on green screen is going upwards, and then it's going to the right, and then it's right round, and then it's now pointing to the left. So that angulation there, that loop, is forming anteriorly. So you've got quite a big loop anteriorly, and on the blue screen, it doesn't look like very much, just looks like a very tight loop. And what you're beginning to form there is essentially an alpha loop. So when you come to sort of try and straighten this out, you're going to need some clockwise torque. Now, that angulation and that distance from on the green screen from the most left portion of the scope to the most right portion of the scope can be reduced by putting the patient on their back. And at the same time, the tightness of the angulation, which is what's making it difficult for you to push the scope in because the angle's very tight. And in a minute, I might get John to draw that for us. If you put the patient on their back, that angle will broaden. It will get wider. So instead of being tight like this, it will widen up like this. So what I would be doing at this point to make my life easier is just putting the patient on their back. The other point to make is with him on his left, the air will be floating up into his right side. As you progress, you'll get less and less view on with the tip of the scope going towards the left, which it will do in a minute. So if it's not too much trouble for the team to just pop the patient on their back, I know the patient's having some propofol. What I want you to do is just in your mind, sort of get a picture of that image on the right and the green screen, and then we'll see what it looks like with the patient on the back. And try and keep the tip of the scope in the same place as the patient's being turned. So this is fundamental ABC of the imager, I think. So while he's just setting that up, what happens when you put the patient from the left lateral onto the supine is this angle of the scope, which is tight like this.
And how that is not a loop, but is a spiral. Okay. Sorry, John.
Okay, so let's just go back to the imager, because one of my previous fellows, who's now my fellow consultant, we were doing a course the other day, and he said, oh my God, he said, I have just understood this now. And we've been training him for years. And this is what we refer to as the anterior posterior. And the idea is you keep it in a two-dimensional plane to resolve the loop. If it's in a three-dimensional plane, it tends to pull the tip back. So you may want to come back and listen to that more than once to get it. But essentially, when you're resolving an end loop, you reduce it from a three-dimensional structure into a two-dimensional structure, and you keep the same plane of the two-dimensional structure to pull the loop out. That's essentially what you did.